Healthcare District Board of Directors.
This meeting is being recorded.
I'm going to call the Seneca Healthcare District regular board meeting to order. And members present, we have Dr. Walls, and we have Ken, and we have Ryan, and Rich, you're on the phone?
Yes, I am.
Thank you, and I am here. Let's go ahead and do the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic which stands one nation, under God, indivisible, with liberty and justice for all. Thank you. All right, moving on. Public comment. Do we have any public comment? I understand we didn't have any comments submitted ahead of time. Is there anybody online that has anything they'd like to say?
I have no one with hands raised online, Jerry.
Okay, let me know if that changes, TK. Thank you.
Will do, thank you.
All right, moving on, we have agenda item number 6, the approval of our board meeting minutes. The board had a chance to review these. Do you have any questions, comments, changes?
I don't have any comments, and I make a motion to approve.
Thank you. Do I have a second?
I'll second that.
Thank you. All in favor?
Aye.
Dr. Wells, thank you. Rich?
Abstain, I was absent.
Thank you. Ken?
Aye.
And Ryan?
Aye.
And I'll vote aye. Okay, so next item on our agenda is going to be our medical staff report, and we don't have any medical staff provider appointments for October, so we will move on to number 8, our policies and procedures. We have our revised skilled nursing 021.003, administration of influenza, pneumococcal immunizations, and COVID vaccines. Does the board members have any questions around this?
Yes, I do.
Okay, go ahead, Dr. Walls.
Regarding the title of the policy, this is just my personal opinion. You don't have to change it or anything, but I would just want to make a comment. I don't know what the difference is between an immunization and a vaccine, other than the proper English, but why doesn't it just say administration of influenza, pneumococcal, and COVID vaccines?
Okay.
Because, and I'll tell you why I care about this. There's too much of political attitude toward the COVID vaccine. Too many patients that watch Fox News and they don't believe in the COVID vaccine. And I don't think we should keep isolating it and treating it differently than any other vaccine. I think it should just be COVID immunization, pneumococcal immunization, influenza immunization. I mean, they're all vaccines. Does that make sense?
Yes, eliminate.
Just put them all in
vaccine
as
and put them
one.
all under immunization.
Yeah, that's what I think.
Okay, I think. we can do
The
that.
public stigma attached with the COVID vaccine has to go away.
I couldn't agree more. Thank you.
Thank you. And I appreciate you bringing that up because the title was bothering me, but I couldn't quite figure out why. So thank you for that, Dr. Walls.
So just as a point of order, is this the way that you like to see them with the red
Yes,
lining?
I was going
Is
to
this
say.
a better
thank
way
you.
of looking at it with the red lining and the?
Oh, yeah,
Okay,
for sure.
Yes, I
We
was going
just
to mention that
wanna
is
make sure.
exactly what we were hoping for, what I was hoping to see. So I really appreciate that. Thank you. It makes it a lot easier for us to see what's changed.
Okay, easier to follow.
So
So
Dr. Walls,
now that I have, yeah,
On the second page then,
Influenza vaccine.
we go back and forth saying immunizations and vaccines here. Do you feel like it should be seen that as well?
Yes,
no, yeah, I see that.
it
I
should be
think
consistent throughout it.
Yeah.
Stick with one.
Mhm.
um,
I think so. I don't think that's a big enough change that you have to send it back to the policy committee, is it? Okay. So then I would accept a motion to approve this policy, making that minor revision and clarification throughout the document.
I will make that motion.
Thank you, Dr. Wells. Do I have a second?
I'll second.
Thank you, Ken. All in favor? Rich?
Aye.
Ryan?
Aye.
Ken?
Aye.
Dr. Walls?
Aye.
And I'll vote aye. Thank you. Okay, so moving on. Now we have our, hold on, I got lost. There we go. Our meeting dates. So for our next meeting, it was technically gonna fall on a Thanksgiving. Normally the December, before the following year, we iron out all the dates, but we neglected to do that this last time. So we need to make a decision on when our November meeting will be held. Generally speaking, we've had it on the Thursday following Thanksgiving when that has happened. And so I want to know if that's gonna work for everybody to do our November meeting, December 1st.
It was originally not going to work for me, but I have a medical procedure and I've changed the date, so I don't really care.
Okay, so December 1st will work for you, Dr.
Yeah, it'll
Walls?
work.
Okay, and what about you?
December 1st, is that right?
Yes,
I think that's fine.
okay. And
Shouldn't be a problem.
okay, and Rich?
That's
December
good for
1st?
me. Good for me.
Okay, thank you. And then we'd also noted on here that the December meeting will happen on December 29th. I don't see any issue with that unless anyone else does.
Nope, not me.
Okay, so we'll go ahead and keep the December meeting on December 29th, but our November meeting will be on
I've got
December.
I've got a question.
Sure,
When does the term of a board member expire?
December 2nd.
Okay, thank you.
Yeah, so we'll have it as an information item on our December 1st meeting so that the public is made well aware and we can start making the arrangements for doing the announcement. Thank you, Rich. Okay, so with that, I think we can move on to number 10. Looks like, is Donna on to discuss a possible special board meeting?
She is.
I am.
Go ahead, Donna.
Sorry for my camera here. Due to the contract for the design build entity for the new facility, we are working through the negotiations on that and would like to request a special board meeting additional to the ones you just described, requesting either November 11th or November 14th to aim to present to you the contract as negotiated for the board's review and approval.
Okay, and Donna, what did legal say about awarding a contract like that during a special meeting?
He said that there's nothing prohibiting. He did say there could be some optics that need to be considered. So I leave that to the board as to whether those are optics that we need to address.
Okay,
These dates were November 11 or November the 14th.
Correct.
Do we have times ascribed to either of those dates? What I'm getting to is 11 won't work for me. I
11 won't.
teach that day.
11 is difficult for me as well. Just I can do it remotely on the 11th.
okay. Can we back up just for a second? Because I know Donna was saying something about the possible optics of awarding a contract. Donna, what if we were to review and discuss the contract during a special meeting and then actually do the vote at our next regular meeting? Would that be an issue?
It would delay the start by a couple weeks, unless we could get the board's approval to begin. Yeah, I think it would delay the start a couple weeks.
Okay.
I'm
Rich,
wondering about Brown Act. Can we put contracts in a special meeting?
well, that's
Well,
what
voters
that's
think
what
that-
I wasn't sure, and I asked Donna to check with our attorney, and apparently they said that legally we can. It's just the optics we need to be aware of whether we want or concerned about that. So, Rich, what are your thoughts around this?
I'm surprised that we legally can do that, but if we're allowed to do that regarding optics, look how many people from the public are at our meeting today. So I don't think optics is a factor.
Well, I mean, there are some, and some review our meetings afterward. They do watch our meetings after the fact. So, I think, what if we do this?
Well, I'm thinking of not people reviewing our meeting, but participating in our meeting.
Yeah. So Donna, do you think it would be possible for us to have the contract ironed out and available within the normal timeframe for our regular meeting, so we can actually have our agenda and the contract out for review within the regular time frame for a normal meeting rather than, 24 hours before.
Oh, yeah, yeah. So you're saying have the edits to you guys the week before instead of, or the final version to you a week before?
Yeah, and have the meeting agenda out within the 72 hours, like our regular meeting. Would that be possible?
Absolutely, absolutely.
What does the rest of the board think about that as an option?
I think for myself, sometimes when we have all these policies and stuff, I really have constraints on my time, and more so now than ever. I just so I have enough time to actually read it, and it's a contract. For some reason, I have a little bit of difficulty understanding contracts. Sometimes terminology and stuff.
Language, yeah.
Yeah,
I know some do it,
I think
you're
a
a
week-
doctor, not a lawyer.
yeah. I think a week would be okay, but I really wouldn't want less time than that.
Okay. That sounds
So
reasonable.
we would have, so are we saying 72 hours or are we saying a week? Just so that I can be clear.
I think a week.
Well, I think, the contract can come out to us for an initial look. We can't discuss it amongst ourselves, but we can provide feedback directly to you if there's any questions that we individually have. And then whatever version is ready to go within the 72 hours, that one can be made public along with our agenda.
Okay.
Does that make sense?
I think-
Let me make sure that there's no legal issue with that, because again, the whole, the quorum issue and, let me confirm with legal that works and I can report back.
Okay. Yeah, you can let me know and we'll just make sure we let everybody know exactly how we're going to handle it.
I
Okay.
think for myself, I would like to be able to talk to someone if I have a question about the contract, rather than waiting until the meeting itself.
Yes.
Do you want
Yeah,
us to open up legal to- or?
No,
okay,
just like
give you
talking to
a-
her or talking to you.
Yeah,
Just,
you should be able to.
just
Okay.
one-on-one, not
Yeah,
not
that's
as a
no
board
problem.
meeting. Otherwise, it gets bogged down in.
Well, if we have to invoke any kind of legal opinion, we can reach out to them and have them expedite.
Okay.
I am a little concerned about the dates of the 11th and the 14th.
Okay, what are your concerns?
Just today, I visit students in their internships, and I sent out notices that I'd be available on the 11th and the 14th.
Oh,
So,
okay.
They haven't
Okay.
confirmed anything yet. But
Well,
I'm
should
a
we look
little-
at some
little
different dates
apprehensive.
then?
So I could conceivably participate remotely, but I know many other people might do that too, and that's probably not good.
14, yeah, I mean, both those days I might have to come in remotely.
When-
Keep in mind that the contract though, the dialogue should happen prior to that.
For the
So
most
this
part,
should be
yeah,
more or
yeah.
less just a review,
formality.
a look at it together. So I don't think it's gonna be a long
It
meeting.
shouldn't be.
Okay.
What about, could we do the 15th? Would that work better for people?
That was one of my dates also. Let's just go with the dates that were, the 14th that was mentioned.
Okay. So if we
Or
do,
you could put it out for a survey and see how many people could participate on. I might know a little more in a couple of days.
yeah, well, so I can do the 14th, but it has to be 3 o'clock or later. So I don't know if that works.
Probably looks better for me later in the day.
Okay.
I'll be joining remotely regardless, but
Okay.
anytime works for me.
Rich, what about you?
3 o'clock works for me.
So shall we say 3 o'clock on the
3 o'clock,
14th?
okay.
And Donna, do you think that will work for what you need to get put together before then?
I do, yes. And then again, I'll talk with legal about what I can get to whom beforehand to make sure that we're not creating any problems there.
Right, yeah, so I think Dr. Wall's ask would be, unless there's an issue with it, for us to receive the draft of the contract the 7th. So then that way.
Somewhere around there.
Yeah,
Exactly.
Well, yeah, but just that way, if there's plenty of time to review it, and then we'll post the agenda and the revised.
And the 14th is what
Contract.
day of the week?
It's a Monday.
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 Okay,
This
Okay.
in here, Jerry.
What's it?
Let me get this entered in my calendar.
Okay. Yep. Okay. All right, I think that's good for that.
You can vote on it.
I guess we could, but I can call a special meeting at any
Okay.
time if I need to, yeah. You guys want to vote on it?
I think we're in agreement.
Okay, I think we are too. Thank you, though. I appreciate that. Okay, next is, it looks like, Donna, we don't have any action items separate from that. So we'll go ahead and move on to our financial reports. Do we have Steve? Oh, there you are, Steve.
Howdy.
Hey, Steve.
So first and foremost, I want to introduce our new accounting supervisor. We have found some help for us and some great help.
Yay.
Kristen, stand up. Say hi.
Hello. Hi, Kristen.
Kristen Courtright. Kristen comes from the Grass Valley area, and she and her husband have relocated to Lake Algonquin. And
Welcome.
she started Monday, and it's been great. It's going to be really a very, very good thing for me personally and for Seneca. So as long as she keeps doing what she's done in the first 3 days.
Slowing down.
Is that with a C or a K?
With a K.
Okay.
Welcome, Kristen.
Welcome.
Thank you.
Congratulations, welcome to the area.
So, with the introduction of Kristen, I will again present a financial report that is in comparison to historical is a month behind. We're presenting the month of August, second month of our fiscal year. Typically at October here, we would be presenting September. And with Kristen here and you guys moving the board meeting out to December 1st, I think we should be in good shape for getting caught up. So presenting September and October. That'll be fantastic for all of us. So August is very, very similar, and it's a shame it's October and we're talking about August, but so hard to remember what the heck happened in August. Well, probably the biggest thing that happened in August this year, there wasn't a fire, right? So, but August was very, very similar in patient utilization of the hospital to July of 2022. And so for August, we did experience a loss of just over 362,000, but that's in comparison to a budget amount, our budgeted loss of just over 301,000 for a $60,000 negative variance. As with September, or as with July, it's being driven off of revenue, and also as with July, it's being driven off our inpatient revenue. So for the month of August, we had a negative variance in gross inpatient revenue of 198,000, and it was in the acute and swing areas, and that's reflected in our census for the month in relation to what we had projected. The acute census, as we all know, is something that's we can project, but we can't really predict too well. The swing bed is something where we can somewhat predict it, somewhat control it based on referrals and all that. And we did have a swing. We had some more swing utilization in the month of September. So we'll see a little bit of a change there. But again, we had a negative variance in gross of $198,000. Outpatient revenue was positive to budget, just over 54,000, but unfortunately, the bulk of that was driven out of our ER. So also with September, we will see more of the revenue on the outpatient side coming out of the clinic as we place a locums provider, locums physician, Dr. Packham. Total patient revenue negative 144,000. When we run it through the contractual adjustment percentages, it results in negative variance in net patient revenue of $56,000. The expenses were all mostly in line with budget. We've talked about the employee benefits and the insurance, where I put our credit from our carrier, insurance carrier, into employee benefits for the workers' comp credit, where previously had been in insurance, and was budgeted in insurance. And so you'll see a slight negative variance in insurance and a positive variance in employee benefits. We also have, we received our audit and our renewal for fiscal 22-23 on workers' comp, and we ended up with a lower rate than what we had put into the budget, which is good. And the lower rate is from us achieving a lower loss experience in the workers' comp area. So that's good credit to Linda McCurdy and her patient safe or facility safety efforts, and everyone being conscientious of safety. The staffing and the contract labor together were slightly over budget. We still had in August, we had our CNA trainees, which is something I did not budget for. So when we go through the CNA program training and get them set for obtaining their CNA license, they do some work on the floor in the nursing home, and failed to budget for that. So just a little bit over budget.
Keep in mind that if I may jump in there, Steve, they all passed, so they're 100% passed RCNAs.
Good.
So that's hopefully offsetting
Fantastic.
our contractual labor.
Yeah,
Sorry to-
yeah, absolutely. I mean, it's
Great news.
we've done the program in the past, and it's a very noble effort to try and do that. It's just where there's no guarantees. We can take the time to run them through the program, and there's really nothing that's going to keep them here necessarily, other than the desirable place to work. But there's other factors that contribute. And so I believe we retained 5 of the 6 graduates.
4 of the 5, yeah.
4 of the 5.
Takes down our contract labor, which is what we're really interested in. So.
The other expense down at the bottom is we're slightly over budget. Is we try to recruit. Jenny Matthews does a wonderful job with the recruitment efforts through traditional means, and she's continued to do so. But sometimes we hit the wall, and so we hired a headhunter, which connected us with Kristen. So that was the initial payment to them for the setup, and then we'll pay a placement fee for Kristen. We also have an agreement in place with that same agency for a clinical lab scientist. So hopefully we'll strike gold twice, because that's very critical. Down in the non-operating expense, we have a small amount in the capital grants and donations. I say small, but $11,855. That was our what we call the small ship grant. We get a ship grant every year to work on quality initiatives, and it runs about $12,000. It's given out to all hospitals that have 50 beds or less. And we received ours for this year, and so that was a positive variance. Any questions about the operations? Okay, so I'm going to go quickly into just talk about the balance sheet. Even with all of the things that went on in the month, our unrestricted days of cash on hand, they actually grew 0.1 day. They went from 252.5 to 252.6. We had larger than normal AR collections. Our AR went down, AR days went down. This is back in August, unfortunately, because we are talking about the September AR in the other report. And our average daily cost or average daily expenses went down. Those two positive things were offset by the loss, and also that we brought down our accounts payable. So at the treasurer's meeting and in previous meetings, we've talked about our cash reserves. We've talked about the interest rate environment, and right now, treasury bills or investments through the U.S. Treasury, a year or less 12 months, 52 weeks, however you want to look at it, are bringing in about 4%. Right now, we have those 252.6 days of unrestricted cash, mainly sitting in what's called the LAIF account, LAIF, stands for Local Agency Investment Fund. It's where public agencies put all their money in, and the state invests them. And theoretically, there's a purchasing power, skilled of investors and all that. And so they're able to get a good return. Their response to the interest rates, the LAIF fund that is, has been kind of slow. As of this week, their overall yield is 1.85%. So we've been talking about maybe we need to go venture into doing some investing on our own, if you will. I know that's a comment, saying it that way, it's a little scary, but so we've done a lot of research. Rich has given me some good ideas and whatever, when you
Avenues.
try and motivate people to do it. Inspiration or whatever it is. To say, let's look at this. So I did look at what our options are. There's a way where we can do this through a thing called Treasury Direct, which is where you can just literally buy treasury issuances. And so that's good. But as I looked at this a little more, I'm thinking that this is going to be a little bigger than just going out and buying a treasury bill or a treasury note or something like that. I'm really thinking we're going to want to put a big part of our money in this. Right now, we have over $13 million in unrestricted cash. Now, once we sign that contract to do the construction, there's probably going to be a chunk of it that's going to be designated for some costs associated with the project. But for the next year or so, I think we're really pretty well in the clear about significant demands on our cash, other than to cover any operating losses we experience. And so I really believe that we can take advantage of this, and we can put $5-7 million into these treasuries. And so to that end, I've contacted Edward Jones here in town. They also work with our retirement account. And I said, hey, you guys, it's brokers sell cheap treasuries and things like that. I said, you guys do this? And they said, we do. And I said, well, send us your investment policy. And I did. It says we can do this. So they're going to look at what it would take to set something up, an account where we would buy the treasuries through them. They would sit in that account. And what we would do is a thing called laddering, which means that we will have maturities over time, whether it's 14 weeks or 13 weeks, 26 weeks, 52 weeks, so that our cash comes available for us to use over a period of time based upon when we might need it. The thing that's odd about the current environment is that right now it doesn't make any difference to go over a year, because 4 is like the 4 1/4, whatever is the ceiling. You go out any farther, it just stays at 4. I haven't seen any rates like that in general that will give us much more money. So we just want to keep laddering it over a 13, 26, 52-week period. And the other thing that's fortunate for us as well is that LAIF fund, although they're invested in things that have maybe penalties or costs associated with liquidating your investments prior to whatever the vehicle is, our LAIF money is 100% liquid. So we take it out without any penalty. And so whatever we leave in there, we're going to get 1.85%, and we'll be able to draw on it and just leave those treasuries in there. So Edward Jones is supposed to get back to me. I imagine they'll get back to me this week. It also, I feel better about having it in a separate account. I feel better having a third party holding the money in an account. We control it, but it's still in that account, as opposed to us having a online account to move around money. But I understand it's kind of the same thing, but
Well, just so you know, I agree with you 100%.
yeah.
Keep it. That's your separation.
Yeah.
That's important. And what's he doing right now for, what's the treasury?
It's swirling around 4, anywhere from
Doubles,
3.8 to 4.2, depending on which vehicle you're talking and which maturity you're talking. So
Steve, did you get my emails today?
I sure did.
Okay, the 17-week was almost 4.5%.
Okay. Thought I saw 4.25, but same thing. So we'll jump on that. That would be something we would grab right away.
So Steve, for people who may not understand how the treasuries work, if we purchase the treasury and that's the percent, that's what we're going to get at the period of time, as long as the money stays there that long, right? That's a guaranteed rate when we buy when it matures.
Yeah, kind of the way it works, like Rich gave the example where it's whatever you just said, 4.5.
Mm-hmm.
So if it's a T-bill, we would buy something at a certain dollar. So we buy it at $1, and then at the end of the maturity, we get the dollar plus the 4.5% over whatever period of time it is.
Okay. Just to make it clear that it's a guaranteed amount. It's not like our investment can go down, right?
Yeah,
We're going to put $1 and we're not going to maybe get a quarter out.
The only thing would be is if you bought a bond or something like that, or if we bought something where we had to sell it before its maturity, and it would be at the market price,
Right.
depending on they handle it. But the way we'll do it is that we're just going to sit on these things, and there's no reason we need to liquidate them prior to their maturity.
Steve, does Edward Jones charge an administrative fee?
That was my next question.
Yeah, what they said is the individual I spoke with said they charge a per transaction fee. She did not reference an administrative fee. Obviously, if they come back to me and say we want a ridiculous amount of money and it's just going to erode in all the profit, then no. But the way that they explained it to me, it's going to be a fairly nominal cost, Rich. I don't want to quote what she said to me, because it's not in a proposal, but the amount that was quoted was very nominal.
Okay, but Treasury Direct, there is no fee, and you can do it through Plumas Bank.
Say that again?
There is no administrative fee for Treasury Direct.
That's
and
correct.
You can do it through Plumas Bank.
I did try and contact Plumas Bank, and I did not get an answer from them.
Because I do that all the time, and every week there's an auction.
That's right.
And the rates are going up. And I certainly agree with you. You don't want to buy the bills with one big lump sum. You want to layer it because they will continue to go up for a while.
Right. And as you know, Rich, you can do the competitive or non-competitive bidding, and so we can direct these people, direct the brokers to do some bidding for us and maybe enhance the amount that we're able to receive. But again, so Sean and I looked at this, and for our investment policy, we're authorized to do this. It says if we have excess funds, we need to move it into an investment vehicle that's allowable. It's attached that this is allowable. It just may need to come to you guys because we're going to create an account. And whether we have to do that through a resolution or whatever, I'll just find out. But so I'd like to bring this back to you guys on the 1st of December. And we'll just have a proposal. We'll have the analysis of the layering, how much money we want to do, show how it's going to affect our cash flow. And then on December 2nd or the next auction, we'll buy a piece of the government.
Sounds like a smart strategy.
Yeah, it does.
I think so. We need to do it.
Has the late fund ever produced returns higher than what we're looking at here?
I haven't seen it in my time here. We've,
They were over 2, but that's about it.
I think for a while it was earning over 2%.
That's
And
why we
then
came up with the
when-
policy, though.
You know, they're investing funds of public entities, so public entities like California code it's like our policy says, it's our priority is safety of principal, portfolio, liquidity, and return on investment. And we can't go into anything that's not like AA rated and typically we want something that's insured, and so I think
Public entities, can you explain that to me a little bit?
just the government, schools, counties, cities,
Us.
hospital districts. Yeah, people that are, organizations that have some public tax support, or in other words,
Accountability.
you're investing the public's money. In the case of Seneca, about 5% of our support comes from tax dollars. The rest of it's from fee for service. So,
I think it's a great idea.
okay, we are on it.
Yeah, it sounds like a good
Well,
strategy.
actually, if you guys are gonna have a special meeting, and I get everything pulled together, I'll
Sure. Yeah, just let
jam this
Devin.
through, because
Yeah.
it's
Just let
not real
Devin.
complicated
Yeah,
if we got the paperwork, so I will plan to do that.
yeah, just let
Okay.
Devin know which one you want it to be on. It's just, I know she's taking note of it right now. Thank you, Devin.
Okay. So thanks, Rich. We're off and running.
Thank you,
Thank
Steve.
Appreciate it.
Okay.
And thanks, Rich.
Yeah, that's it for the financial report.
Okay. Thank you, Steve. With that, I would accept a motion to accept the financial report.
I'll move to accept the financial report.
Thank you, Ken. Rich, do you second it?
Second,
Thank you. All in favor, Dr. Walls?
Aye.
Ryan?
Aye.
Ken?
Okay,
Rich?
aye.
And I'll vote aye. Thank you. All right, moving right along, number 13, Brown Act Amendment. Do we have any change here?
I think,
Discussion of
I think it's
virtual meetings.
unchanged. And Judy helped me out here. I think indications are that we might be experiencing a surge along with our winter months, similar to influenza. So I think that we need to just maintain a hybrid. And in my report, I'll be talking about the public health emergency that's going away.
Yeah.
So we'll be staying on top of whether AB 361 applies any longer.
Yeah, I was going to ask if that goes away, what does that do? to
So I
this?
do have
Yeah.
people keeping an eye on that to see what happens with AB 361. But I think for this board meeting, I'd like to make a recommendation to the board that we continue our hybrid.
Okay. And I would like to put out the idea that even if AB 361 goes away, all that means is that our board members need to be here. So I would suggest we still have it open for the public to attend
I'm
virtually if
open
that's
to whatever the
possible.
board says look like.
Okay. Does anyone have any opinion on that?
No, I think that's a good idea.
Okay. All right, thank you. Okay, next up, Steve, you're back.
Yep.
HRG.
And so just to keep you on your toes, we're talking about September for the HRG accounts receivable report. And there's not much here either. The total AR days crept up just slightly, went from 52.2 to 53.1. And as I mentioned in the financial report, that is considered to be within our range of what we call best practices of 45 to 55 days. We're still, you could read in the summary, there's still battles going on to continue to collect accounts and resolve some issues on larger claims, mainly in long-term care. We also have we did have, as I mentioned, a swing bed claim in September that takes a while to resolve, and when it does, it's a big settlement. We get a large payment for longer lengths of stays. We get very good payment from Medicare, but we have to wait till their inpatient count is settled, and we have to wait for the patient discharge, because with long lengths of stay, it can overlap months, month to month. So anyway, that's what we got there, and field any questions or comments or?
I don't Any questions? Anyone else have questions for on the HRG report? Rich, anything?
No,
Okay. Thank you, Steve. Appreciate it.
Kristen and I are gonna step away, but we're gonna join, we'll be on the video if you have any questions.
Okay, great. Thank you.
Thank you very much.
All right, next up, we have item 15, critical access hospital report. Donna, are you on?
I am.
Welcome back.
Alrighty. So diving into the document that was provided. CEQA NEPA, what I have here, I've gotten further updates from what I had presented a week ago. I had been misinformed or misunderstood, whichever is more appropriate, that they had completed their field work. So that's what I had reported. However, I have since found out that that is not the case, that they completed their initial field work inclusive of the Collins Pine area, and will be reporting back to us on that. But there is the additional work. There is more work to come, and the CEQA NEPA process is delayed a bit, speaking frankly. So I'm trying to wrap my hands around with the consultant where we are with this, and where it falls in with the schedule as proposed by the design build entity that we are working with that to negotiate contract. So
sorry to interrupt for just a quick second. Are they planning on coming back to do more field work?
As I understand it at this moment, they are under current change orders that have been approved. So at this moment, I don't have any information beyond existing change orders that have been approved, but that they haven't completed the work.
Okay, because my understanding was that they were supposed to coordinate with us when they came out in the first place as the owner of that property. And I don't believe they did. So
that is
are
correct.
they going to back out and coordinate this time on their own dime?
So it's not that they, you're correct in that they didn't coordinate with us as we had requested. But it's not an add to what they had already gotten approved. So they're not asking for more money. They're just needing to come out again to do some more work.
Okay, I think I would again ask that they coordinate with our administration when they do come. That's a potential liability for us, having some, people on the property without us even knowing when they're going to be here.
That was the request, and that request will continue.
Yeah. Okay. Yeah. Thank you.
Yeah, we're 100% on board with that, and we'll reinforce to them, have reinforced, and will continue to reinforce with them that is a requirement.
Thank you.
And I'm assuming this means they're going to walk the ground again, and snow's on the way. It's my whole point here. Okay.
Yeah, there's we're communicating with them, making sure they're aware of the snow season and how that fits into their schedule. Yes.
All right.
Thanks, Donna.
Okay. Heliport, they did walk the path and do their field work for the flight path over Collins Pine. I'm waiting for the official feedback on what they found there, and we'll be able to report back to the board at a later date on that.
Can I just interrupt for a second?
Mm-hmm.
Sean, can you tell me, as far as the heliport goes, once it's built, is there any maintenance or cost in keeping a heliport?
Yeah. So it'll be a concrete slab heated. We have to maintain lighting. So whatever lighting we have, I think we're going to be doing pilot controlled lighting. Is that correct? So we have to just make sure that the lighting comes on. So there's a little bit of maintenance that happens, but it's pretty minor. Okay. Yeah.
Periodically, I would assume maybe some repaving or
If it's going to be concrete and it's going to be heated, I'm hoping that it sticks around. We might paint a big H on it occasionally.
Yeah, that's right.
Well, a big painting party,
Okay.
but it's going to be pretty self-contained.
Okay, I was just curious.
Yep.
Alrighty, and then as far as Hullaport, we don't have, beyond the CEQA, we don't have further information on that to date from previous reports. Harvest Plan, no update from the 929.
So, real quick here, Donna, I see on your report that the DOA, DOA expressed no concerns.
Yes, that was from a previous report. I didn't
That was a
update that. It's but yes, they have reviewed it at a high level conceptual review and have indicated that they don't have a concern with the one flight path.
Good.
Yeah. Okay. Harvest Plan, same as what was presented last time, where they're waiting for the CEQA NEPA results to move that forward, and have I'm in communication with them on that, what we're getting from the CEQA NEPA consultant. The Wildwood easement, the good news there is that the Plymouth County Community Development Commission approved the easement that this board approved at the last Seneca board meeting. So they approved it at their 10/18 board meeting, and I don't know if Roger has been able to reach out to Deborah to coordinate final signature, but that's the communication, is getting Roger's signature from PCCDC and then getting that recorded.
Good news.
Yes, definitely. And then again, we'll be talking more with them about how they conceptually have are in alignment with the need for our secondary access, or the desire for our secondary emergency access through their property. It's just we wanted to get the design from the design build entity before we bring that back to them officially. So that's still pending. No update on the LAFCO annexation. It's all subsequent to the CEQA NEPA, and so that's, with that being delayed, the LAFCO annexation has been delayed. The ballot measure, no update. As we know, the ballot measure is for November 8th, and that information at that point. USDA financing, we did receive initial feedback from USDA regarding some additional declination, an additional declination letter from a conventional lender, as well as clarifications on the request submit on the request to the lenders. Steve's working on that, and Steve, I think you said next week is the plan for that. Correct.
Donna, oh, sorry,
Yep.
he's, thank you, Steve. Is the USDA, did they reschedule coming out and doing their walkthrough?
They did. They canceled and they haven't rescheduled. So I don't have a new date for that, but I can make sure that I keep you informed of that.
Okay, thank you very much.
Other funding, the Senate Bill 395 funding was approved. And so we're just waiting to hear on that one for the more information to come in January of 2023 on that, as to what the magnitude of that is. And then we continuing to look at the philanthropic goals for the project through the Seneca, through Seneca's work on that. Schedule, we're working on validating that now that we have these proposals from the design build entities. We are validating both schedule and budget, and we'll report back on that at the special meeting we just discussed on November 14th. And then design, to that end of validating schedule and budget, we did receive 2 proposals from the design build entities that were two of the 3 that were shortlisted from the RFQ process. The third had bowed out during the process, and so the 2 that we received were obtained on 10/10, and then presentations were observed by the strategic planning team on 10/13. We are, based on the scoring, again, that will be presented at the November 14th meeting, we are working on negotiating contract with the Bolt HGA team. And we'll have both contract value and contract terms identified, obviously, within that information presented at that next board meeting.
And Donna, if I may, just real quick here, you know, we really had wanted to have the full board involved in reviewing these proposals from all these different entities, but we were advised by legal counsel we couldn't do that during a closed session. And the proposals have, you know, trade secrets for those entities, and so we couldn't really do that in an open session. So that's why we went ahead and, as a strategic planning group, did the review, and then you guys will see the one that received the highest score from those two proposals. Go ahead, Donna. Thank you.
Yes, thank you for clarifying. Yes, and I believe that concludes my report. There's no changes on the medical equipment planning. The focus right now for the project is definitely getting this contract for design build entity and getting the CEQA NEPA on track with the schedule. And of course the ballot measure. Those are the three highlights that they are the most pertinent at this point.
Thank you, Donna. Does anybody have any questions for Donna?
Thank you.
Thank you.
Okay. Thank you, Donna. All right, Sean, looks like you're up.
Okay, a brief CEO report this month. I can tell you much attention focus has been on educating the community. There's been a lot of interest. There's been at least 5 scheduled gatherings where we were able to share information, and I've had over a dozen ad hoc discussions. The community is interested in what's going on. We're there to provide them information associated with both the bill and the bond and other things that are going on. So I could just tell you a lot of attention in the last month has been paid on providing information in preparation for November. Donna just spoke about the new hospital construction bidders, and that'll be presented in the special board meeting. It was a really good process. I'm very, very pleased with everybody that was there. A lot of good questions asked and a lot of good stuff happening. So legislative updates, I just want to bring forward that the public health emergency there's a date to end in January. There's a potential that California is going to hang on to the PHE for another 90 days. It's to be determined. The only thing that really does for us is it just changes some regulations around our use of telehealth. If the PHE goes away, we're looking at, Judy and I and Ann have been working on ways, taking a look at telehealth options as it relates to chronic pain management, things like that, that are not affected by the removal of the PHE, because we do need to continue our telehealth processes. We just want to make sure that we can continue them as is when the PHE is gone. So we've been looking into what how that affects us. So that's the big legislative updates. I can tell you there's some more coming down the pipe. So in the next few months, there's going to be some more legislative updates coming, because there's a lot of stuff happening in healthcare right now, as it relates to bills being introduced. Some of it, just to tell you, there's been another bill introduced that relates to financial relief associated with 1953. Everybody feels like it's dead in the water, but it's at least being reintroduced. So we'll see what happens.
Who's introducing it?
I can't remember the representative. It's the representative from Wairika again, but they're coordinating with the 2 representatives from Southern California that also have districts and critical access hospitals that are going to be severely affected by this. So there's a lot of wrangling going on right now in Sacramento. So we'll let you know. Seneca campus updates. The technology refresh is completed. Our server room is absolutely beautiful. Both server rooms, my goodness, we ripped a lot of stuff out, and now it's very concise and put together. The cooling is better now. It's not hot. It's not as dusty. It looks good. I'm experiencing some changes from speed perspective. I'm looking right at Dr. Walls on this one. But all of our switches are in. We have our new VM in. We've got a couple of things to do for some cleanup, but we're going to start adding. That's the biggest thing is just our entire network revamp. It's nearing completion. Some things that we're going to start adding, into our VM space is the voice over IP system. We'll be talking about that. So our new phone system will be added into that. Our digital transfer capability in the imaging space, which means no more burning of CDs for transference of patients, and the security camera long-term storage, so that we have the ability to store long-term and get our security system locked up and make live visibility to our nursing staff and our ER staff. So what's going on outside, they'll have visibility to it at all times. And good, it's good stuff. So we're getting that going. The Cerner EHR, there is a report in here from Brian, our program manager, but I just want to let you know that we're still in the alignment phase, which is basically getting everybody aligned toward the build, the learning portal. So going in the day in the life of, I would really like to incorporate our physicians into that learning portal so they can at least get an idea of what the day in the life looks like for a doctor. And Brian is on, I know he's on. So physicians need to see what a day in the life is going to be like. I can tell you that the response has been a little slow in getting to the learning portal, but Brian is in there cheering everybody on to get in there and take a look. We do have some really big dates coming up with SMEs from Cerner, subject matter experts from Cerner as it relates to the individual builds. So we are headlong into this thing. We're going to start heading into the build phase, which is going to be really important.
This is something our managers can be encouraging their staff to do as well.
Right now, the learning portals are for the managers, the subject matter expert leads.
Okay.
They should, getting comfortable with that. And Brian can speak to it. Jump in here, Brian, anytime you want on this particular portion of my report, or you can just go through yours.
No, sure. We did get all the employees signed up in the learning portal. When I'm on site starting next week, that's when we will start. We wanted the SMEs and super users to go through it first in case any of their staff had any questions.
Okay, that makes sense.
Okay, so we're going down the path here. Brian's doing a really good job of keeping things wrangled. So I'm going to give him some props. The voice over IP system, so we have kicked that off. We are going through taking a look at, we're going to be doing an inventory of all of our phones, our extensions, our fax machines, everything that's going to go associated with building out the database, the new database. We're in multiple conversations throughout the day about how it's going to sound and look and feel for consumers. I can tell you that as of right now, we do have an 800 number. We have not sent it out there, but we actually have the 800 number tied back to our 258-2151. Our number is going to be 833 call SHD. So that's it's going to be 833-227-3743. That is going to be the number that gets us into the hospital and gets us to our operator, gets us to our phone tree, gets us to extensions. So there's going to be a very, very big push with Chelsea's group as it relates to communication out to the community. All of our documents that have our number on it's going to get changed and things. Keep in mind that we are going to be forwarding our old phone number to this for a period of time with a message saying about the change. So we're trying to do a slow communication out to our public, give them access, but give us slow communication for change.
And is our switchboard operator, is that technically the title?
Yeah.
Okay. Are they going to be located in the clinic?
They are.
Okay.
Yeah, we're moving them into an office. They'll be right in the clinic itself. So, yeah, it's going to be the voice.
Good.
So I just have a question. When you get the new phone system, are you planning on having receptionists in the doctor's offices, or will the staffing just be a medical assistant and a doctor?
Well, ultimately, there will be reception up at the front, but doctor's offices need to take calls. So you'll have an extension that the
But
public
that's what
can-
I'm getting at is
Who answers
they'll be able to call directly with the extension, but who's going to answer it?
Good question. We're really early into this discussion around that. I can tell you that when calls come in to Dr. Bachman's office right now, the MA is doing it. They're answering. If the MA is busy, it rings back to the operator and they're able to manage it.
Okay.
So there's somebody who's going to pick up. If they say Dr. Wall's office, or they ring in, if everyone's busy, it rings back. The operator will say, they're not able to get the phone right now. Let me take a message, or would you like to ring into their message machine? I can transfer you into their voicemail. But let's talk about that because we're still working through some of this.
Probably still, the switchboard operator would have, needs to be asking more questions. You're kind of a gatekeeper. Like, what are you calling Dr. Wall's office for?
Is it for appointment?
Authorization? Is it for to schedule an appointment, what have you, and can hook them up with the appropriate people at that point as well.
Yeah.
Well,
Or you can
that's
speak with
what
Dr.
I'm
Walsh.
getting at is then, because if we don't have a receptionist, who's going to making the appointments?
Right. And so-
Because I will tell you, when I go to these doctors down in the city and I call like Enloe Cardiology,
Mhm.
one person does the scheduling for all those cardiologists.
Correct.
And so I have a cancellation. Cardiologist isn't going to be available, you have to reschedule. So I call back to reschedule. Well, no openings for 3 months. Oh, wait a minute, I had an appointment, you canceled. But you can't talk to the doctor's office.
Right.
You're just talking to one person. And I tell you, it gets, if I could switch cardiologists now, I would. That's how frustrating it gets. And I just think that people in this community will be the same way after having had access to their doctors. And I don't know if you can have one person that would know the intricacies of each individual physician
Right.
and have the ability to schedule patients. Like I take walk-ins in my office. Another doctor may not take walk-ins. And then there are a lot of things like that that are going to be really difficult.
Okay, yeah, these are, so we have just literally started working through these things. There's no decisions made at this point, but there will be changes, but these are the kinds of things we have to consider is where's the concierge side of it versus just becoming this sterile thing. You know, there's a blend and let's try to find that blend. But at this point, we have nothing drawn down on paper at this point.
It's an
Other
interesting
than-
discussion, though.
What's that?
That's an interesting discussion.
It is, you know, I
The
don't.
nuances of it.
We want the efficiencies, but we also don't want to take away the charm, I guess is the way to say it. But, and there's a way to blend those. Back to the VoIP, I think the switchboard operator though is going to be that voice that can help people wayfind. We have to walk through some of the workflow pieces. Okay, good stuff. We'll be in conversation with you on that, Doctor. Help us with that. Position recruitment and mid-level recruitment just is a continuation thing. It's just a placeholder. And then unchanged from September on the projects underway and completed projects. Nothing's changed at this point. Nothing's been completed. That's my report. Any questions?
Thank you, Sean. Anyone have any other questions for Sean?
No, well, just one thing about the outdoor signage is it prudent to do it now or to wait until we're a little further down the road with the new hospital?
We have it, we're doing our outdoor signage where it's actually changeable.
Okay.
So we can change arrows, you know, ER that way, ER that way. We actually have a design for that.
Oh, good.
Yeah. So we're,
Nice, Chelsea.
yeah, we just could change the arrows, flip it upside down and slide it in.
I don't think it's probably that easy, but.
Yeah.
All right. Any questions, Rich? Guess not. All right. Thank you for that, Sean.
Yes.
All right, Judy, you're up.
Okay, so we had a brief conversation with our public health officer earlier this week, and just a reminder that flu season is on us now. We're definitely seeing it in Plumas County. The question came up from him about whether we can run like influenza, RSV, COVID, all on a single swab, and we can. We can do, it's a nasopharyngeal PCR swab that we can do and run all the tests. And he thinks that there could be a little more activity coming out of Senate, but we're not. We're running all of COVID, but we're kind of leaving RSV and flu behind, and that should be part of our differential as well. So we put out a
So we're
reminder.
gonna automatically run for all of them then?
It's in
or-
order,
It's in order,
Okay.
yes.
but we should be running the spectrum, if you will, especially this time of year.
Yeah.
Yeah, it's a little more uncomfortable of a test because it is a nasopharyngeal, but then we can really see what's going on because we're so COVID focused right now that we really need to focus on the other respiratory illnesses that are happening currently. Let's see, we did add another resident to our long-term care unit this week, and so that brings us up to a census of 14, while we're continuing with our long-term care refresh project.
Do we have additional space available now or not yet?
Not yet. No, we need the flexibility to move residents around as we move from room to room. but we're getting there. We did have our skills fair. It was very well attended and very well received by our licensed nurses.
Where did you hold this? Was it, did you guys do it here
We
or?
did it in our education building.
Oh, okay, fabulous.
Let's see, and then really what we're experiencing right now is a lot of regulatory surveys. So we have had 4 surveys in the last 3 weeks. So they came in, we had an unanticipated visit one day, and this really seemed to be kind of an insider job because we believe it was a former employee because it had to have been from someone who knew some of our processes in the emergency department, et cetera. And so she came in and she had this laundry list of things that this person had written up, but there were 0 deficiencies and she was quite happy by the time she exited. And then last week we had our 4-day survey for our skilled nursing facility. And they didn't make it easy on us, but by the time they left, the findings were so minimal, they were actually correctable within about an hour. And we had a radiation survey, and that was 0 deficiencies. And we had another survey today. He just left the building around 3:30, and that was our life safety, where they come back into the skilled nursing, but they're looking at additional things such as, well, actually, they're looking at all of our facilities. That there was 0 deficiencies on emergency preparedness and 2 minor issues on storage, which are going to be easily correctable. So, but they have not really been out in the field for nearly 3 years. But now they have hit the ground running and they just keep coming back to Seneca. And,
We're expecting another one soon.
we're expecting another one.
Are these all unannounced?
Yeah.
Except for the radiation survey, these are all unannounced. So they
Kudos to you
show
and your
up
staff.
to administration and we find out what they're here for and then
They do
we
it.
escort them and we do not let them be unescorted at any time. So
Yeah.
but we do expect them back to do the rest of the hospital because that was really distinct for the skilled nursing. And now we expect any time we'll have that and look at the good access.
I just want to tell the board that I'm immensely proud. I mean, I've been through lots and lots of surveys, and I got to tell you, squeaky clean. I mean, the things that they're finding are so infinitesimal. They're just so small, and they're easily fixable. So I just want to put kudos out to the staff and management because they're on the ball. They're doing what they're supposed to be doing. So good stuff.
Great work.
And that's all I have unless anyone has any questions.
Thank you. Any questions for Judy? Rich? All right, hearing none. Thank you, Judy. Thanks for all your hard work. Okay, looks like next up we have Brian. Are you still on the line?
I am here.
Oh, thank you. So thank you for providing this report. It's pretty clear to me. Do you want to talk to it at all?
Sure. I mean, this is a very simple snapshot. Do you can you scroll it up on the screen?
TK, are you?
Okay, you're there. Can you bring it up?
Thank you.
So,
There you go.
one of these things coming from the outside and from a larger facility, not a huge facility, and coming in and seeing TK and our team, you've got some very bulldogish and aggressive staff here that's going to keep you on track once I'm gone. So I feel very, very good about working with your staff here, and it's a great environment to come into again. What I want to talk to, like Sean started, we're in the alignment phase, which is really just kind of a lot of background work in Cerner, setting up meetings, setting up access. The real work will start on the 8th when we have our workflow meetings, and it will be a challenge for a facility like Seneca here, because the 8th and 9th, Cerner typically expects all the super users and system experts, subject matter experts to be available, which with your working manager and working staff, it's a very challenging thing. So we are having to move a couple of sessions around working through the OR because there's a ortho surgery on Tuesday. You typically have surgery on Thursday. So we are making Cerner kind of adjust their flow to what Seneca can handle. So after that, the weekly, bi-weekly meetings will start with the teams. And then the big event will be after the first of the year when it's train the trainer. So Cerner works in waves. There's, these big, heavy days. And then there are just an hour or 2 hour meetings a week with some testing and some workflows going on. We have all the super users and subject matter experts in the learning journey. This is something that you will have forever. So as you bring new employees on, you have a built-in learning tool for new employees. We will start giving access to the general staff so they can position themselves and get familiar with what Cerner looks like and what a day in the life work looks like. And the only real risk that Sean and I are really managing is we have 1/3 of the long-term care team in place, which is the documentation team. And we are not going to let Cerner slide and try to push us to delay long-term care past our go live date of 4/24. They need to supply us with MDS and long-term rev cycle people. I got confirmation today, trying to clarify that one staff member said it was out of scope, and I've got confirmation that it's not out of scope. They will get us the resources, and I should have that next week. The other thing is kind of what you were talking about with patient access and scheduling and referrals and things like that. As we're going through the phone system rebuild, we need to keep in mind the digital front door that Cerner will make available to you. We saw a huge drop in office calls for referrals and authorizations and renewals by using the portal to communicate with the doctors. So, a patient gets home at 6 o'clock at night or on Saturday or Sunday, they need a referral, they need a renewal, they can send it through and it gets processed out. So, we will leverage those tools to make Seneca a much more patient-friendly front-facing entity as well.
Yeah, Brian, just for Dr. Walls and for everybody, so they're able to, through the portal, message their physician. So when you come in the morning, you'll see a message there, and maybe something as simple as, "Hey doc, I need a refill," and then you can message it back saying, "Well, I need to see you, so let's make an appointment." So it's the communication tool is direct with the doc through the system. So it's a nice thing because then it can go straight to the doc for a quick question.
The ease now with getting refills is they come directly from the pharmacy.
That too.
And all
You will get that as well.
That was yes. Yep. Okay. Sorry, Brian. Go ahead.
No problem. No, there'll be those efficiencies, and some of that work can be offloaded to other staff members to prep all that work for you as well, doctor. So you're just signing it off.
So when we're talking about super users, we have physicians identified as super users to be trained in part of that process.
Physician isn't a super user, is it?
Well, for the ER, the physicians in the ER, we have one. Dr. Nielsen is going to be the super user for the ER. And once again, I want to caution us. A super user tends to really customize certain things for their specific specialty. We are adopting model experience. So there won't be a lot of customization. So super users aren't going to have the level of intensity of the build that you would normally have in another procedure or another facility, because it's going to be very cookie cutter model. Brian, you want to add to that?
No, it will be, but you will have, before go live, as the doctors receive their training, they will get concierge service, which helps them build their favorites to speed up the process.
At the elbow.
At the elbow, and go through so that your ear infection protocol is really a click for you, and it will build your order sets in your meds and everything like that. So that's the part that's going to be customized for the providers. The general build will be built off model. So when there are any updates or any changes or any new enhancements, like they're rolling out monkeypox right now into the system, that it will just take, TK and her team won't have to do any break fix type of things. The things that we have to will be done is just the customization of those favorite order sets for those providers to help them speed through the process.
Okay, I'm just, and I appreciate all of that. I'm just thinking about the clinic though. I'm not hearing, how are we involving the clinic? Okay.
Well, no, yeah. I mean, you guys will start getting your learning journeys. The
Doctors, Brian.
see that as well.
I would love to have one of our physicians step up and be the go-to in the clinic. Dr. Walsh, you want to be the super user in the clinic?
I don't know what a super user would do.
Basically, it's you're going to be, say there's order sets that, and like Brian said, there's order sets for an ear infection. You want to standardize them. So you go to Dr. Ware and everybody else and say, hey, here's what we're thinking for an order set for this disease. What do you think? And they say, yes, okay, I'm a super user. Now we're going to build that as a standard order set. Doesn't mean you can't alter it, because you have to have that capability as a doctor.
Well, you're not going to build it. You're going to tell
You're
them
just going to
what you
tell them
want.
what you want, right?
No, that's correct.
Right, Brian?
And with that, there are quick visits that we can build as well for those type of visits, and that's kind of where that physician super user will help kind of guide. They are there in the system, but if there's anything specific to Seneca that we need to tweak, we can.
So it's pretty standardized. The super user would be, if there's something that's special for us, which there shouldn't be, then we would have to incorporate that. We'd have to gather you and say, hey, listen, what do you think about this?
Well, yeah, but I mean, if you've got visiting doctors like Dr. Jensen, he would have to be his own super user.
Oh, I guarantee you, he's bringing everything he learned from PDH over here. He's starting to build templates. So he'll be a super user for OR, for sure, for endo and things like that.
Maybe you get a cake, Dr. Wilson.
Yeah, we get you a cake.
Yeah, and I'm thinking more along the lines too of at least having, a familiarity with how it is set up and how it's gonna work before they flip the switch, because,
Well, that's something certainly. So the learning journey, Brian.
Yeah.
We have physicians learning journey.
Yes. Yeah. No, those users have been built, and that's what we'll start rolling out next week. There'll be two basic sessions that are just generic Cerner ones, and then we'll get into the family practice or the individual type of providers training. Now, I also still have access to my old training system. I will be on site for the next 2 weeks. So any provider wants to do some dry runs and look arounds, I can sit with them at a time and show them what we had built at my old facility.
I think that'd be tremendous if you feel like jumping on to it. Basically, what he's saying is the Cerner. I imagine that's your test system, right?
Yes. It's a train system. It's all de-identified data.
What a day in the life of you would look like.
Yeah, actually, that was a question I was going to ask, is where on this flow sheet the doctor comes in.
Right there in the.
So it's in Activate. So that's why
You're the orange guy.
Yeah, this is why I was able to work with my old facility, because we really struggled with that as well. As we're building the system, we're building the orders, the forms, the information, but there is no content. So you don't really get to see what the second visit is like, what a follow-up visit's like, what it's like to look for information. So, because my old facility struggled with this so much that, they allowed me to keep access through November 16th to help you guys along with that, because Cerner should really give us gives the end users a sandbox to play in much earlier than just before go live.
Yeah, and that's partly where I was going with that. It sounds like if Dr. Walls, if you're able to sit with them and kind of see how it worked, then you would know if you thought there needed to be any changes potentially.
Yeah, at least it's at least the flow.
Yeah.
So when the doctor comes in and you log on and you get in your landing page, all the stuff you're going to be able to see on that one page, for the patient, what it's like to go through a visit, what's it like to go through a secondary visit, what's it like to document, what's it like to drop down and add an ICD-10, I'm going to order an XYZ, drop down, here's all the ICD-10s that are acceptable.
Yeah.
You know, those types of drop downs and just how the flow works.
Well, I
Jerry,
just
this
still
is
remember.
TK. I just wanted to mention that Dr. Jensen has extended an invitation for our physicians, if their schedules can match, that they go down and visit with him on a clinic day, and he can show them what he experiences, at least down in Quincy.
Oh, that's a good idea.
Yeah, thank you. for
He's
that,
offered
TK.
that up.
That's great.
Yeah. Great.
So
Thank you, TK.
what is, again, what is the go live date?
August 24th,
August.
April 24th, we're going to be transitioning over.
I appreciate the timeline, the way this is laid out here, and I like the idea, we are here.
Yeah, we are here. It's like going to the mall.
Yes. We will be green next episode. We will have gone through workflow and training. And we'll be preparing for the train the trainer situation by next month.
Thank you. I appreciate all of that information. Any other questions, comments? No? Rich,
Jerry,
anything?
this is TK. Just one comment in regards to Cerner from the patient perspective. Next year, we do plan on offering a public presentation to help the public learn and get comfortable with the new patient portal that they will receive with Cerner.
That's great, TK. If it's possible for us to record that and make it available on our website, that really would be fantastic in case somebody can't be there.
Okay, we can do that.
Yeah,
Here's like a how-to.
great. Thank you for that, TK. Let's see. I'm just wondering if Rich, do you have any questions?
No, I don't. Thank you.
Thank you. All right, thank you for that, Brian. We look forward to moving forward with this project. It's exciting. All right, next up, we have our departmental reports. We have our compliance report. Looks like we'll have some QA coming to us for our next meeting or for our December meeting. And it looks like we have a couple of items that we're looking at whether they're going to impact us. We don't know yet. Looks about right. Anyone have any comments about compliance report, questions? Thank you. Okay, IT report, there's a lot going on here. I think we kind of covered most of this, TK, unless you have anything else to add. I'll take that as a no. Thank you. All right, now we have our HR report. This all looks very nice, and I appreciate the newsletter, and I really love the reflection that you put together here, Sean. And all the rest of this newsletter. I just think this is an amazing, amazing tool and great for communicating. I did have one question for Jenny. I was wondering, and I've wondered this before, but I've never asked. When we talk about open positions, why don't we list our open positions perhaps as well?
Open position. Yeah, we've never incorporated that as.
Yeah, I just was wondering why, if there's a reason for it.
For what now?
We're recruiting for family medicine physicians, but we don't put it on as an open position. I was just kind of curious why we don't do that.
Is that because they're contractors, or is that because, okay?
Yeah, I mean, I can certainly provide
Or just another heading there.
something, in my report that says, the open position filled, or interviewing for candidate received.
Well, kind of where I was going with that, at least when we used to have the Chester Progressive, this is what would be in the Chester Progressive as our ad, and we would never had positions. And I don't know whether we have this information online somewhere. It's just a thought about trying to add it elsewhere where we're recruiting for other positions in Seneca.
You never know, somebody could be looking at Plumas News.
Well, or wherever else for advertising. So,
Okay.
it was just an idea.
Something to do.
Anyone have any questions for Jenny on her report? Comments? No? All right, thank you, Jenny. And then Chelsea's report we have up next. If I can find it. Here it is. Lots and lots going on here. Thank you for this, Chelsea. JD, anything to add? Any comments? Do you want to talk about the Red Cook-Off at all? The cook-off was very successful. They have given us approximate numbers of around 70,000 for fundraising. They still have to take out expenses and things like that, so we should hopefully have final numbers soon. But I even got an email on Monday with another donation through the foundation, and it was under the title for the cook-off donation. So stuff's still trickling in for it, which is great.
That is great, yeah.
But it really, for us, it was about awareness. So it was a big awareness.
Yeah.
There's been a lot of conversations about philanthropic giving, and many of the conversations I have is everyone's kind of waiting for November 8th. Because it gets really real after that. And then, so,
Hopefully.
kind of watching, everybody's watching. We're having a watch party.
Watch party. Except we can't because
we can't,
our
because
results won't
we
certify
won't
that
know.
quickly. All right, thank you. Anybody have any questions for Chelsea? Okay, then we will adjourn to our closed session.
Here we go.
This meeting is being recorded.
All right, closed session is closed, open session is open. There were no actions taken during closed session that need to be reported. Items for our next agenda, do you want to add informational results of the November 8 election for the bond measure? Also informational that there will be a board vacancy, candidates to be considered at the December 29 meeting. And we will have a closed session for public employee evaluation, CEO, and an action item for the investment proposal that Steve discussed earlier. So our next regular board meeting will be on December 1st at 3 p.m. in the LAC conference room. Thank you, and meeting adjourned.
Good meeting. Thanks. Take care.
Thank